Hi, my name's Phil McGee. I am a physical therapist of 15 years that is board certified in geriatrics. And if you haven't seen my first video, Why I Left Clinical Physical Therapy Part 1, I will leave a link down in the description. And today I wanted to talk about more reasons why I chose to leave clinical physical therapy and move on to a non-clinical career. In my first video, I discussed 4 different reasons why I chose to leave clinical physical therapy, those being unsustainable productivity, having a poor work-life balance, having issues with Medicare reimbursement currently and having to deal with that in the future, and then also having a decrease in census in 2020. In today's video, I'm going to talk about 3 additional reasons why I chose to leave clinical physical therapy. The first being that I didn't like what my options would be if I were to remain a clinician while leaving my home health job that I had. The second being that I didn't see much opportunity for advancement if I were to remain a clinician. And then third, the issues that come with having patients that weren't improving. Once I started to look at my different options of being a clinician but leaving my full-time home health position, I started to see that I didn't like the different options that I had. The most appealing option was to get out on my own and to either be a Medicare-based physical therapist or to be a cash-based physical therapist. While I was looking at my different options, I went ahead and purchased a cash-based physical therapy course, and I also joined a few different Facebook groups that had some therapists that were doing only cash-based, while there were also others that were doing a hybrid of insurance and cash-based practices. And I started to see an ongoing issue, and I acknowledge that there are great ethical therapists that they understand the difference between medical necessity and what is wellness, but I was seeing that there was going to be this ongoing ethical dilemma, at least for myself, where I was having to try to determine, is what I'm going to provide medical necessity, or is what I'm going to provide a wellness service? I really started to question what was medical necessity. And despite becoming a board certified geriatric clinical specialist, there really wasn't a whole lot that was on that board exam that was looking at what was medical necessity and what was wellness. What I was finding was that most of the time, a decision of whether something was medically necessary or whether it was wellness was based on what was the practice that the person owned. So if someone had a cash-based practice, then justification was made for making it wellness. If someone was a Medicare provider, then there was justification to make it medically necessary. And I didn't like having to make this constant determination of whether or not what I was going to do as medically necessary or wellness as what benefited me. When I started to look at my different options outside of non-clinical, I was seeing that I would either have to be a clinician or to be a manager or to be a professor. Those seemed to be the only options that I had. If I were to remain a clinician and to go out on my own, I didn't like the risk that was involved with doing that I didn't know for certain where my next paycheck was coming from. It was all going to be based on how I built my practice. If I were to go into management, that seemed really unappealing to me because I have seen how many of the managers that I work with, how many hours that they put in, and oftentimes there were even worse cases of work-life imbalance. If I were to have gone the professor route, I did see that as an option, especially that I got my board certification, but it seemed like that was going to be an uphill climb to try to get to where I needed to be. The third issue that I wanted to bring up was having difficult clients. And now, when I say difficult, difficult can mean a lot of different things. Most of the time, when I'm saying having difficult clients, it would be someone that I tried all sorts of different techniques, all sorts of different ideas, and they weren't getting better, or that they were getting better very slowly, and there's lots of different reasons why that happens, but it was really demoralizing to have all this energy put in toward trying to improve someone's quality of life, and the improvement was minimal. Sometimes it didn't seem to be happening at all. It was really disappointing. And there were other issues that were happening, that there would be people that I would get them better, and then after they've been discharged, then a few months later, they get another referral for physical therapy, and either they were pretty much the same as what they were, or that they were worse, and it was this revolving door of having physical therapy, getting better, being discharged, and then after a period of time, getting another physical therapy referral, and rinse and repeat. And it was pretty demoralizing to just not be able to see someone sustain what they had improved on with physical therapy. Another issue that would come up would be involving pain, and pain is really complex. I have taken multiple different courses when it comes to pain, and what I was finding is that there would be a lot of people that I just couldn't seem to help get better, no matter how many continuing education courses I took, no matter how much I learned about pain neuroscience education. There was this really defeating feeling of having someone have pain that was depending on me to try to help coach them through the issues that they were having, and not really feeling like there was that much improvement. One other issue involving difficult clients would be the lack of caregiver support. Oftentimes, if someone was at an assisted living facility, or they lived alone, or they didn't have someone who consistently could help take care of them, there would be issues involving compliance with a home exercise program, being able to follow through after discharge, as I had mentioned before, that revolving door. It was just something that seemed to be an ongoing issue, and especially when it comes to medical necessity, you can't just stay in as a physical therapist just because they need to have someone to do their exercises with them. And I was finding that to be a frequent issue, that there would be physical therapy referrals because there was no one to work with them on what they had already been taught, or you had someone that had dementia or memory issues, and they didn't have the support that they needed to have someone help them with their home exercise program. And I didn't like being put into that situation where you're giving bad news about having to discharge someone because they don't have someone that can consistently follow through with what their exercise program was. Today I've discussed 3 different reasons why I chose a non-clinical career and to leave clinical physical therapy. The first being that I didn't like my options if I were to remain a clinician. Second, that I didn't see much room for advancement if I were to remain a clinician. And third, that I was having issues with difficult clients. Thank you very much for watching this video and hearing my reasons for leaving clinical physical therapy. If you've liked this content, please hit the like button and subscribe. Also, feel free to leave a comment if there was something that you wanted to ask or that you want me to discuss in a future video. And I also have different services on my website that I do provide a free ebook on creating a non-clinical resume. I also do resume review services as well as doing interview preps. If you are interested in any of those, you can go to the website. I will leave a link in the description. And thank you again for listening to me, and hope to see you in the next video. Bye.